All right. Well, today we're talking about in the trenches. Let me share my screen. And let's make this big. There we go. So we're going to be down on the absolute operational level. This is an orientation for people who have to do facilitation in a practice, that they know what some of the issues are. I don't know, you know better than I, from the role of facilitator, how welcome very specific operational suggestions will be from you. And it may be that they're quite welcome, and it may be that because some of my suggestions will be different than the place that you're working, you may want to think about them, or you may just want to talk about them with leadership rather than with everybody. So I'm urging you to use your judgment, but I also want you to be sure that you know what you're looking for and what is generally happening in the field, what some of the learnings of the field are. I hope that you have 3 handouts, 2 handouts that are notes about the way to keep records in primary care behavioral health, and 1 handout that is a sheet on billing for Medicare and Medicaid in New Hampshire. Just because you're going to go back to that, people are going to make statements about what's billable and what's not, and it will help you to have an authoritative reference to go to. So here we go. I also want, I spelled resources wrong here. Just wrote this as we were coming on the air. Okay. To remind you, or to say to you, consider using resources as you go on. The Integration Academy has 2 particularly useful resources for when you are talking to the leadership in the practices that you're working in. One is called the guidebook. It's the guidebook of, I'm not sure, professional practices, I think it's called. But it's essentially a in-depth study of 9 of the best or most exemplary integrated practices in the country. And so you find out what the mission, the high level mission kind of level of those places, what keeps them going, what gives them their spirit. But you also find out what people say or what they do or how they cover in very specific situations. So you know how those things play out in action. And being able to visualize it, if you're not a clinician, is very helpful. And then the playbook is something you could do with a practice if they are committed. If they're interested in integrating behavioral health, it allows the practice to locate itself on the continuum of toward integration in a number of dimensions, and then to see what the next step is. And so I think both of those could be great resources for you in the future. Here we go. So one of the places where things break down early sometimes is around the exchange of information. It's not that that's hard for your medical colleagues usually. They're fine. But your behavioral health colleagues may very well get hung up. We can't talk about this, or we can't write this down, or this is not something that we can share. And you need to have some authoritative place to go back. The passion with which people talk about the exchange of information is so much more intense, and most of it is cultural. Very often, people will be just wrong on what the law and the practice is in primary care for behavioral health, but that will not diminish their certitude. And I've seen several situations where the mental health clinicians essentially take the lead on this because they're so sure. And the medical clinicians kind of back off because they never heard of all this, but whatever. And so they end up with a badly distorted program where people can't communicate about basic things because of the mental health clinicians' fervor. So here you go. Information may be exchanged. This is all straight out of HIPAA. May be exchanged within an organized care delivery system, which is either an integrated care setting, that's pretty clear, or an organized system in which participating entities make public their joint arrangement and do one of the following: joint utilization review, joint quality assessment and improvement, or share financial risk. What that means is, in an integrated setting, information may flow freely. You do not need to go back to the patient for signatures within your own system. And within your own system may at some point mean an ACO, but it certainly means a primary care practice. The second part is if you wanted to have a exchange of information with another agency, like between a health center and a mental health center, this is what you have to do. You have to have a joint arrangement, which usually means a memo of understanding, MOU, and do one of the joint utilization review, joint quality assessment, share financial risk. And you have to make it public. So everybody who comes into either place knows that we are in an arrangement with Smith & Jones Mental Health Center, and we share information for the benefit of our clients or our patients. If you were going to do an MOU like that, it needs to talk about the populations to be served, what information will be routinely exchanged, any practice pattern data to be exchanged, the types of scheduled meetings that you're going to have, and some arrangement about if there's a population that you're serving and one area is serving them more intensively and another less intensively, how you distinguish who's going when, where. And that program doesn't have to be that every patient in Smith & Jones Mental Health Center, they are free to exchange information with the health center about it. You have to clarify who those patients are. People in our Frontier program, our program for people with severe trauma, whatever it is, it's got to be clear. Then there's the issue of psychotherapy notes. Psychotherapy notes do have a protected status. I think that even psychotherapy notes are fine under the above that we talked about, but I'm not pushing for that because psychotherapy notes are a distraction in primary care. And they should not be, I simply say, don't write psychotherapy notes to all the clinicians. In order to not write psychotherapy notes. They have to learn to write progress notes. Progress notes are fully broad enough to do anything you need. So a psychotherapy note is not. In other words, these things do not define a psychotherapy note, and they are medication, prescription and monitoring, counseling session start and stop times, modalities and frequencies of treatment, results of clinical tests, summary of diagnosis, functional status, treatment plan, symptoms, prognosis, and progress to date. That's right out of HIPAA. Another source I've said that progress notes can include a description of the major events or topics discussed, specific interventions used, your observations and assessments of the client's status, and any plans you may have for the future. In other words, that's all the notes you need. The difference really is when you are doing observations of the client or patient in the room with their responses, observed responses, and to topics. In other words, you're doing a description that is sort of like a film of what's going on in the interaction. You're in psychotherapy note land. If you're doing an abstraction to the sense of saying major events or topics, you're in progress note land. If people in your place don't write psychotherapy, don't write progress notes, that should be something that you talk with leadership about their practicing. Now, one of the things I gave you, well, we'll do this when we get to charting. We'll go into the notes that I gave you. The last one is 42 CFR. 42 CFR requires consent. It's a good law in the sense that there was a time when people would go for alcohol treatment, and folks like the HR officer in their office would know they went for alcohol treatment, and it would come back to bite them in their job. And so this law was made to protect people from the mere fact of their getting treatment or the mere fact of their having a diagnosis being a complication in their lives. And the main goal was so that people would go for treatment, so they wouldn't have to fear treatment. That's not how it works in medical settings. So a service is not covered by 42 CFR if it holds itself out as a general medical service, meaning not a specialty substance abuse or substance use service. If the information was not generated, the information about alcohol or drug treatment or diagnosis was not generated by a subunit identified with substance abuse diagnosis and treatment, and with the treating professional does not have substance abuse diagnosis and treatment as their primary function. The bottom line there is, if you have a behavioral health clinician who is doing a lot of work with people with substance abuse, and you name them our substance abuse counselor, they are constrained by 42 CFR. You have cut them off from talking to their medical colleagues without an additional signature. If, however, you call them our behavioral health clinician, they are not. They are a general behavioral health person in a medical setting. And so there is an urge in a lot of places. We need to get substance abuse counselors. We need to get special substance abuse systems. And if you look at the impact of 42 CFR and what that causes, you may be gearing up some of those systems, but you don't want to be naming them as substance use specialty systems. Let's talk about charting. So, one of the things you probably should do in these places is have a handout about our behavioral health program that says we share a chart and this is how and we communicate. It's not legally required, but it just keeps you from having somebody who's been socialized in a specialty mental health setting getting concerned or being surprised. Surprise is really the worst thing, that you are talking to their physician. So you want to have a handout where everybody sees, yes, we all work together as a team. And the language has got to be about team and about your health, not about we share information, we share your secrets. When you start charting, since it's going to be in the medical chart, where there are requirements for behavioral health billing, like social history and medical history and so forth, the whole chart is up to you, is yours. So it is not, you should look and see if there's a social history there in the chart. It's in the chart. You don't have to do it again. If there is a medical history in the chart, there's no question about it. So the whole thing that you have when you are in a mental health center, where you don't know this person from Adam, you don't know what the risks are, you don't know anything about them, you have to do an hour and a half kind of meeting just to find out about them, to see what you're going to do. In primary care, they're already our patient. They're already in took. You don't have to open the chart. And you don't close the chart. You just write in the EMR. You need to learn to chart efficiently. If you get out the handout that has text in it, you will see that those are very brief notes. Each of those notes, with the symptoms and the intervention sections, are notes that are going to go in the chart. So on the one hand, they got sent to the physician with notes that were related to the physician and their treatment of this person. They respond back to the PCP after a first visit. That's good. That's typical. But the same note gets copied and pasted into the chart in that approach. The other approach is the one that I used, and it is the handout that you have in front of you with all the check boxes. I had a long go-round with the compliance department at UMass Memorial Health System, and they helped design this. So this was designed by lawyers. And what they said to me was, the company that's paying has every right to know what you did, but they don't have the right to know the content necessarily. So if you're writing it in text, it's hard to say, well, I did cognitive restructuring. Well, I guess you could say that, but it's harder to go through and list all the little things that you did. But if you have it in front of you in check boxes, you can check the things that you did. And you'll see there that there is a risk assessment involved. There are billing places to say how long you were in and what you were doing. There are places to note any homework. things that happen between sessions, and it's set up in a problem/goal approach. So it's what I would do with that was we couldn't put it into the EMR for reasons too long to discuss. It was doable and it would have made things much slower. So I would just fill one of those out and then copy and paste it into the note section in the EMR. Worked fine, dropped right in. And I would add about 4 or 5 sentences of text there in the middle, and that would be what I would read back to the patients when they came back, so that there was some orienting text that my colleague, the physician, could read, and that the patient and I could read again, that would get us back on track in terms of what we were working on and so forth. Those are things that you can offer, talk about, think about with leadership. Now the issue of space. I started out saying Cherokee is the exemplar in the design of space. That's what I mean. This is their actual building. And what you see is that the behavioral health consultant's office is flanked on both sides by pods of 3 exam rooms. And so on the outside walls of the consultant's office there on each side, there's a little shelf there where the doctors and nurses do their charting. And they work with those 3 exam rooms. And it means that the behavioral health person can be pulled in to be part of anything that's going on for 2 docs all the time. And sometimes for others around the floor, but mostly that's, two docs doing a busy practice that keeps everybody busy. That's, I guess, what you might call the ideal if you think that behavioral health is really core to what's happening in most of the visits, or one core element, and they do. So the architecture houses a model of understanding for them. Not everybody's like that. So the next best thing I have found is that if you have a long hall, that every 5 or 6 exam rooms, you have a consulting room, which is a place where anybody can talk to patients. Not just the behavioral health person, because there are times when docs need to sit with somebody. A consulting room tends to not have an exam table, but to be the same size. If you can't do that, then you just use open exam rooms. I can't tell you how many visits I've had sitting with one arm on an exam table, or drawing graphs or whatever on the paper on the exam table. Please try not to give behavioral health clinicians their own office somewhere. They will go in there and they will hide, and you will not see them. And so because there's always more paperwork to do. People don't get efficient at paperwork unless you squeeze the paperwork a bit. And so if they go in their office over there on the other hall, pretty soon you're just going to have a co-located service, and nobody will be coming out to hang with the docs. You want a place for them to sit near the nursing station, or even if to have their face be seen. Another way to have people interact is to have them do their charting together. So in a number of sites, they have these sort of big bullpens of places where docs go to chart. Lots of computers, and they do their writing or they do their follow-up kinds of writing. So that they have a EMR in the room, but when they have to do other things, they go to one of these places. And you have your behavioral health people there so that when they are thinking about their patient, they see the behavioral health person in front of them and say, oh, gee, we should talk about that. There, as you can tell, there's not a right and true way, but the default way that people think of mental health needs its own space. It needs a quiet space. It needs a homey space, with a lamp and a fern. That's what I'm trying to counteract. Scheduling. The behavioral health clinician should be scheduled on the same system as medical. I would just use 30 minutes as the basic unit initially. Maybe sometimes it'll be shorter, but in general, I would make it 30 minutes. One of the things you can do if you start to have unkept appointments, or if you have behavioral health people in the practice who aren't there full time, they come for a couple of days a week, is to have an open clinic. And on the open clinic, which is a half day sometime, the behavioral health team, whoever they are, whether it's one or many, are available without appointments, without a schedule, and anybody can walk in. And that's how you start. It's not just for people who don't keep appointments. What you say to the physicians is, that's how we start, is people come to open clinic first, and then we make a time, unless we have a warm handoff. If we have a warm handoff, then I can schedule somebody later, and they'll come at that time. But if we haven't met them before, they should come to open clinic. And that way, all the people who say to the doctor, yes, I would be glad to go see those people, or I would go see Dr. Blunt, who are not telling the truth because they just want to get out of the visit, which is very common, won't end up on my schedule and not coming. I mean, you can have a 50-60% no-show rate when the docs are really referring a lot of people and scheduling a lot of people who don't want to come. You expect people who aren't scheduled, aren't in a visit, to be out somewhere where they can be found. You would like to have a system where that can schedule 2 people for the same time, so that the behavioral health person can say, I'll drop in and say hello to the patient when next time you come to see your doctor. And so then you can say to scheduling, schedule this person with Dr. Jones and put me as a drop-in. And so then that you both have the space to see the person when they come back. You get a lot more people agreeing to be sort of regular care that doesn't involve a commitment to therapy. And then you also get used to, if you're the behavioral health clinician, talking to people in the huddle or consulting with the docs. You don't have to see everybody. Let's talk a little bit about sustainability. If people are starting out with the idea of, does this pay for itself, the behavioral health service, is it going to pay for itself? The answer is probably not, and don't start. Think about the analogy. Do you say when you get a new nurse, is she going to pay for herself? No, you don't say that. You say, can we afford to add this resource for our patients because we think it's better care? Think about behavioral health the same way, except behavioral health will generate some money. Except behavioral health will generate some money. No more on that. Places where this really works tend to have bundled payments with major payers so that you get payment for taking care of the whole person. As soon as you get to bundled payments, all of the what were we doing for fee-for-service stuff becomes an issue that you want to move beyond. And if you haven't moved beyond it and you still have a fee-for-service mindset, you're actually in difficulty. I have a little bit on advocacy when people won't be impaneled, if they won't impanel somebody, or if they won't, if there's issues about payment with payers, think about making partnerships with other folks, other practices in the same boat, and going after these folks. I mean, go meet with the biggest payer, go to legislators, or go to the Department of Mental Health and say, this is what we need. People at the top level get committed to integration, but have no idea about the pieces that need to fall into place. And if you come and say, if you want these people to get served, you're going to have to do this, all of a sudden you can often find things will shift. You can be aware of many sorts of revenue generating activities. The most important one that people tend to miss is that when a primary care behavioral health model is working, doctors tend to see more patients. And so the revenue that's being generated by behavioral health intervention is sitting there on the medical side, credited to the doctors. You have to go find that. Means that you have to know how many people we're seeing before these folks came and now how many they're seeing. And you have to have talked to leadership about the fact that this is likely to happen. And it has been shown to happen. There's also funds for expert in some states, some payers. Some of the privates pay for expert. Behavioral health screening is paid for by many payers. So if you're doing a PHQ-9, you can get paid for that. Sometimes it has to be other than the annual physical. If you do it on the annual physical, the payer thinks they already paid for it. But if you do it any other time, then they'll add extra money for it. The health and behavior codes is something that's really important, but isn't yet workable in New Hampshire if you have a Medicaid population, and I'm sure everybody you work with does. So I'm not going to spend any time with that. How did I do that? Okay. You should, the thing at the bottom here is you should bill for everything, assume that you should track everything, but there may be lots of things you won't bill for. And you're going to give away some services, so don't sweat it. And don't organize people by who's got coverage. It just jerry-rigs the whole issue of working together. You just have to face that sometimes your trainee is going to be seeing that person and they have coverage if someone else saw them, but they don't have coverage with the trainee. You got to let the trainee see them. If you want, there's a really good tool that the Farley Health Policy Center has put up called the Coach Cost Tool. And there's a link. And it's the way you look at it is to sign up as a practice and go through the structure. And you will be able to predict about what you're going to get out of all of this work. Maximizing fee for service is also part of it for many people. And that is that, for instance, you get used to billing for small bits of time. Don't give them away. It's got to be really easy for the behavioral health folks to drop a bill. If you are going to have a warm handoff, don't just shake hands and say, I'll see you Tuesday. Do an intervention. Talk to them and add value in some way. Teach them a breathing exercise. Give them something to think about during the week. Give them something to track. And then you can bill for the time. The minimum is about 16 minutes. It is not hard to reach 16 minutes. If panels are a problem, that's another place to, we already talked about that, to get your friends together and go get them. When we're talking about sustainability, sometimes the codes to do the billing aren't in your system, and you have to spend the time and the money to put the codes in. We had a big problem with that at UMass because there was a lot of billing we couldn't do because they said it's too expensive to put in the codes. And also have flow sheets in the electronic health record for your screening data. If you have screening data that's in the text of a note, it is useless. You can't go back and find it. If you have it in a flow sheet, it can be captured, it can be manipulated, it can be found later. And so you also have to have someone who's assigned to enter that data. If you just have sheets of it piling up and nobody's whose job it is to put it in, it won't happen. It's worth it to engage patients in the transformation by giving them the brochure that I talked about that describes learning skills or reducing stress rather than therapy for things. I wouldn't use the word therapy except for things like occupational therapy, where it has to go. Be ready to outreach to people and engage them. If you think that it would be helpful for behavioral health or for health behavior change to happen, be ready to reach out and call them. This isn't mental health where we only want to talk to you if you want to talk to us. Behavioral health availability is really important in all of this. The last is metrics of assessment, which is sometimes as people start assessing programs, they use folks from an academic setting who are researchers, and you'll be sitting in the meeting and you'll hear them say things like, wouldn't it be interesting to know? And at that point, you know that you are sliding out of assessment and into research, and it is not going to do you good. So you want to be sure that if the payer doesn't need it and the regulator doesn't need it and it won't help you deliver better care, don't spend your energy collecting it. Sometimes you're going to be collecting things about your own process and sometimes about outcomes. If you want to talk more about, or if the practice that you work with wants to talk more about assessing their practice and helping to create data that helps them to iteratively improve, that's what the Center for Behavioral Health Innovation does. And so you might want to have them call those folks. I hope that was useful, and I'm going to stop there. Let me ask if there are one or two questions, and then I'll get out of your way.
Any questions?
Okay, and I will stop sharing my screen, and I will stop recording.